Night eating syndrome, or NES, is associated with variations in circadian levels of melatonin, leptin, and cortisol. These hormones are connected to important regulatory biological mechanisms, including sleep, appetite, and stress, respectively. Lowered levels of melatonin in NES sufferers are linked to their frequent sleep disturbances and insomnia. Decreased levels of leptin, a hormone released from fat tissue to suppress appetite, at night may be connected with increased nighttime eating associated with the disorder. Cortisol, a hormone released due to stress, is elevated throughout the day in patients with nocturnal eating syndrome. This elevation is associated with the fact that episodes of nocturnal eating are linked to stressful periods in an individual's life. Furthermore, the increase in cortisol is likely linked to an overexpression of the HPA axis, which is activated by stressful events. It has been suggested also that the pathophysiology of NES is connected to the levels of serotonin in the brain. The role of serotonin is implicated by an increase in binding of the serotonin transporter and the efficacy of selective serotonin reuptake inhibitors in the treatment of the syndrome. In an attempt to take a more in-depth look at NES, let's turn to the neuroendocrinology of the syndrome. One study was conducted in the Clinical Research Department and the Laboratory of Gastroenterology in a university in Norway. The study included 12 night eaters, some of whom were obese and some of whom were of normal weight, and 21 control subjects with similar body mass indexes and ages and genders. As expected, the night eaters experienced more nighttime awakenings, about 3 per night, than their control counterparts, who experienced almost none. As I mentioned earlier, melatonin plays an important role in the regulation of biological rhythms, especially the sleep-wake cycle. Melatonin can help to induce sleep, and hypomelatoninemia has been linked to disordered sleeping. The figure on the screen depicts the circadian changes in plasma melatonin levels throughout the day. The overweight and normal weight night eating groups are depicted by the filled-in triangles and filled-in circles, respectively. The controls are shown by the open triangles and circles. As you can see, melatonin levels in the night eating groups were lower from 10 p.m. to 6 a.m. than their corresponding controls. The lower melatonin concentrations at night seem to explain the frequent sleep disturbances associated with NES that prompt patients to wake up. Upon waking, their hunger sets in, and they feel a need to eat before they can fall asleep again. As I mentioned, leptin is an important hormone for the regulation of appetite. Its release serves to inhibit food intake. Normally, with increases in adipose tissue, so too increases the concentration of leptin circulating throughout our bodies. In keeping with this assertion, plasma leptin levels were higher among overweight individuals when compared to the normal weight groups. The pertinent evidence with relation to night eating syndrome actually lies in the relation of the NES groups to their respective control groups. As shown in the figure, which follows the same legend as the previous one, the nighttime, 12 a.m. to 6 a.m., increase in plasma leptin levels was lower in both of the night eating groups. This attenuated increase in leptin at night could explain the increased appetite which leads to hyperphagia in nocturnal eating syndrome. Without functional breaks, so to speak, an NES patient's appetite will run away from them, impeding any attempt to control their behavior and ultimately leading to uncontrollable weight gain. As illustrated in this next displayed figure, plasma concentrations of cortisol were higher in the normal and overweight night eaters in comparison with the controls from 8 a.m. to 2 a.m. A follow-up study built on the elevated cortisol finding, describing a weakened response to exogenous corticotropin-releasing hormone in night-eating subjects compared with controls. This data suggests a resulting adaptation in the HPA axis due to the constant stress associated with the cortisol elevation. These circadian hormonal variations seem to distinguish NES from conventional eating disorders, such as anorexia nervosa, bulimia nervosa, and binge eating disorder. Additional differences lie in the frequency and size of nighttime ingestions. Sufferers of NES eat at night very often, while a study led by Mignot et al. demonstrated that only 6 out of 40 patients suffering from binge eating disorder experienced episodes of nighttime eating, and these episodes occurred only once per week. Also, in comparison with bulimia patients, who ate approximately 8,000 calories during night eating episodes, NES patients only consumed 1,100 calories. These nighttime snacks are usually carbohydrate-rich, increasing circulating levels of tryptophan that enter the brain where they are converted to serotonin, facilitating sleep. In addition to the conversion of tryptophan into serotonin, there have been additional studies suggesting a possible role for serotonin in the pathophysiology of NES. Some have demonstrated that selective serotonin reuptake inhibitors, including sertraline and others, are effective in lessening the frequency of nighttime eating episodes. To test the underlying factors behind this effectiveness, researchers at the University of Pennsylvania analyzed the relative presence of the serotonin transporter, SERT, using neuroimaging techniques. Using a radiopharmaceutical in conjunction with single-photon enriched computed tomography, or SPECT, the researchers assessed SERT binding in the midbrain, medial temporal region, and the basal ganglia. The study found that patients with NES had significantly more serotonin transporter binding in the midbrain when compared with controls. Statistically significant differences, however, did not exist in medial temporal regions or the basal ganglia. These images are the atom SPECT scans of controls represented in the top series and NES patients shown on the bottom. The arrow on the bottom left image of each series is pointing to the midbrain. As you can see, there is a more concentrated binding of the radioisotope to the serotonin transporter in the bottom series, again, which depicts patients with nocturnal eating syndrome. When it comes to sleep-related eating disorder, or SRED, and Kleine-Levin syndrome, or KLS, the neurological mechanisms and relevant neuroendocrine variations are much less well defined. In the case of SRED, however, several pieces of evidence suggest that dopamine may play a role in the pathophysiology of the disorder. First, the incidence of SRED correlates with restless leg syndrome and periodic limb movement disorder. Dysfunction in the dopaminergic system is the key mechanism for both of these disorders. Furthermore, dopaminergic agonists have shown to be effective in the treatment of SRED, either as monotherapy or in conjunction with opioids. Additionally, hypnotic agents such as zolpidem or Ambien and other non-benzodiazepine GABA-A receptor agonists, along with psychotropic medications such as olanzapine or Zyprexa, used to treat schizophrenia, have been shown to exacerbate SRED and cause a higher incidence of episodes. In Kleine-Levin syndrome, neuroimaging studies have shown hypoactivation and hypoperfusion in the thalamus and hypothalamus during KLS episodes. More specifically, left medial thalamic perfusion was reduced by 25%. Additionally, metabolite ratio changes in the thalamus occurred during symptomatic periods. Glutamine metabolites in the left thalamus and basal ganglia increased during these periods. These abnormalities in limbic function are consistent with the emotional and behavioral dysfunction associated with the syndrome. I wanted to end my presentation by saying thanks to all of you for a great semester, and please email me if you have any questions. Thanks.